The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Good day to all you TMD folks, all of people out there who are network providers for TMJ services, and interested doctors who may be interested in joining our network. I'm Tony Urbanek, and this is TMD Demystified, and today's topic is entitled the Urbanek device versus Nightguards and Botox, etc., etc., etc. Today I decided to confront each one of the usual kind of accepted treatments out there for TMD that actually do not directly address the cause, which is inflammation within the temporomandibular joint. I've touched on this many times through different episodes, and in a couple episodes touched on a service or a provision done by another provider or in the past. But today I want to confront as many as I can think of and compare and contrast what is usual and customary out there for the treatment of temporomandibular joint disorder, disease, symptoms, versus just treating the inflammation within the temporomandibular joint. I recently did an episode on the logic and illogic of temporomandibular joint treatments and touched on these slightly. But today I want to get into the basics of each one of these, not to be critical, not to show how wrong others are in their evaluation of this problem or treatment of this problem. But frankly, with my long experience, it really doesn't make any sense. It's illogic to try to treat symptoms just to treat the symptoms and not to treat the cause. As I've explained many times, inflammation within the temporomandibular joint in conjunction with the autonomic nervous system sends out an autonomic signal throughout the side of the body or both sides of the body that are affected by the inflammation in the joint and simply says, tighten up. We know that muscle trismus has a lot to do with the symptoms, but the muscles themselves are not the cause, or the overstimulation by bruxism is not the direct cause of what's going on with the inflammation itself. I mean, bruxism can cause damage and inflammation. Trauma can cause damage and inflammation within the joint. Functional malocclusion can cause damage and inflammation within the joint. But it's the inflammation itself that is a common denominator and causes directly all these symptoms through the administration of the autonomic nervous system, sending out signals to tighten up. If you can make the inflammation go away, the autonomic signals go away, everything relaxes, and the usual and customary symptoms of headache, earache, jaw pain, neck pain, shoulder pain, arm, hand, finger tingling and numbness, and locking diminish. The three symptoms of ringing, fullness, dizziness that work through a separate mechanism and are a direct result of inflammation getting into the middle ear, which was a separate and distinct episode that I recorded several weeks ago. But let's get into it a little bit here and confront each one of these, because for those of you already in our network of providers who do the Urbanek device and protocol, you will be faced with patients and other friends and dentists and physicians who say, what about this? I heard about this. Somebody said this treatment works really well. Well, let's go through these 101 and compare and contrast. That's all I'm trying to do. And again, the preliminary discussion I just did outlines why, if you just diminish, get rid of the inflammation within the joint, you don't have to do any of these treatments that are directly related to one or more of the symptoms, while you're ignoring other symptoms that the patient may be having and may not even be aware of coming from the temporomandibular joint. Hopefully I've made that clear. So the first one that just comes to mind, I put on the list here, is occlusal equilibration. There is a whole group of theory and treatments and well-intentioned doctors who kind of specialize in occlusal equilibration for temporomandibular joint disease, knowing that if the teeth fit together well, it has some kind of effect. Well, yes, it does. It certainly doesn't address any of the problems that are associated with the second category of TMD, which is tinnitus, subjective hearing loss, and vertigo. But if you equilibrate the bite and you have a nice functional bilateral bite, it certainly does decrease the loads on the joint. Whether or not it decreases the loads on the joint enough to get the inflammation out of the joint is questionable. I think in some people it might, and definitely in some people it doesn't, because we know that there's a huge number of patients who have had their occlusion equilibrated a time or two and still have, over a period of time, symptoms related to TMD. So equilibration can help in some cases, but it's much easier to just unload the joint completely. If you unload the joint, the inflammation goes away. If inflammation goes away, which causes all the symptoms go away. That is not the theory. That's the action of the Urbanek device and protocol. You have to unload the joint long enough. You can't just do it for 30 minutes. And the protocol reads that you start out with the device 24/7, separates the back teeth, unloads the temporomandibular joint. And then after usually 2 months, it's time to move on to nighttime only. And there are variations of that, but most, very, very, very true, most patients will be able to document significant decreases in their symptoms, starting out with 24/7, then going to nighttime only in a very simple way. The occlusal equilibration would include dental reconstruction to make the bite more functional into a centric occlusion. Keep in mind that if you're going to do that, you need to do your best to make similar centric occlusion to centric relation, because the larger the difference is between CO and CR, the more potential you have for overloading the joint. Differences in a significant decrease in CO-CR will, over a period of time, overload the joint, cause inflammation, which then causes the cascade of events creating TMD symptoms. Next in mind is physical therapy. I have a lot of friends that are physical therapists. It's a very great profession. They do wonders for certain types of physical ailments. But to my knowledge, the physical therapists concentrate on the muscles themselves, decreasing muscle trismus using different methods. And then the most common, the newest treatments that I've been aware of is dry needling. I think I understand the theory behind dry needling, and that is, you're not injecting anything into the muscles themselves, but if you have a muscle intrismus and you put a series of needles into the muscle. It stimulates the muscle to react and relax. They're decreasing the trismus once the muscle relaxes. The pain in that particular area goes away. I've documented one case where where dry needling has created a pneumothorax. So you can have some very serious, and I'm sure my case is not the only one in the country. If it happened to me here in Nashville, Tennessee, it's probably happened elsewhere. A pneumothorax is not a minor event. And in this case, took a trip to the emergency room and a placement of a tube, chest tube. Not a minor event. In any case, that's the theory behind dry needling. But again, you're just addressing that muscle or series of muscles that the patient is complaining about. That patient is, if that neck or shoulder pain is coming from inflammation in the joint, I can promise you that patient has a plethora of other symptoms related to this inflammation, which could include any of those: headache, earache, jaw pain, neck pain, ringing, fullness, dizziness, etc. That dry needling and that physical therapy addressed to that muscle system is not addressing. So they've missed the opportunity to treat all of the other symptoms associated with the problem. Drugs, big, huge category. First one is nonsteroidals, as I've mentioned many times and well-known, well-accepted. Motrin, Tylenol, or aspirin, the usual nonsteroidals, are very effective for a short period of time in relieving inflammation. And that is why they work really well for a short period of time with patients with TMD. But very shortly after the first 2 or 3 weeks, symptoms persist. Patient continues to take the nonsteroidal. The nonsteroidal is not effective significantly effective beyond 2 or 3 weeks. What it is effective doing is causing gastritis and pain in the stomach, and everyone complains of that. Literally everyone complains of that. It self-medicates with nonsteroidals for a long period of time and can be dangerous. I have had one patient who was placed on the liver transplant list because of self-medication for nonsteroidals, and one who had a kidney removed because of renal damage due to self-medication with nonsteroidals. A long period of time. That happened in a few months. But these patients who had TMD symptoms, they didn't know what else to do. No one else could help them. They went around and around in circles, and they over-medicated themselves to the point where they had significant liver and renal problems. Muscle relaxants. Muscle relaxants, again, address the muscles. You take a medication for muscle trismus, and it, to some extent, will help relax those muscles. That's what they're written for. But it doesn't address any of the other symptoms. And of course, you then medicate indefinitely. And what we see here is patients are commonly given muscle relaxants, and it doesn't address the actual pain that they're having in any particular muscle area, which is stimulated by that reaction, autonomic reaction of inflammation in the joint, causing everything to tighten up. So you don't need muscle relaxants if you can figure out a way to decrease the inflammation in the joint adequately, which works really well by just unloading the temporomandibular joint by disoccluding the posterior teeth. Think of the device itself, which is a tool, like you would think of a set of crutches for the knee. If you unload the knee long enough, if you have inflammation in the knee, now you may need, a total knee reconstruction, replacement, but it works just as well to decrease the inflammation and the pain if you just take the load off of the knee. And of course, it's not convenient to spend the rest of your life on a set of crutches. So there is some differences between using a set of crutches for the rest of your life and using this device every night for the rest of your life. That's the trade-off. So yes, you have to use it indefinitely. You have to unload the joint consistently and constantly, because if you discontinue the device, you will load the joint eventually to the point where you begin having inflammation and symptoms again. Well known. That's why it's a protocol. It's an Urbanek device, quote, tool and protocol. And the protocol is full-time, 24/7 for 2 months to get the initial inflammation down low enough, and then every night for the rest of your life. It works. Narcotics and opioids. I've seen more than my share of people addicted under various circumstances, but very many people addicted to opioids that are prescribed opioids that have these significant pains. Fortunately, it is not as common as it used to be. Years past, and I don't mean many years past, within just 5 or 6 years past, certainly 10, 15, 20 years past, I saw a lot of people addicted to opioids who had temporandibular joint disorder and all these complaints and pains, and they were given a large amount of opioids and became addicted. That's pretty self-evident. Not a good idea, but I still see a few cases of that occurring. Neuroleptics, antipsychotics. Unfortunately, when the doctor doesn't know what else to do, he may, when I say doctor, I mean PCP, he may elect to use some neuroleptics with the theory behind it that there's so much anxiety to this patient and they continue to clench and grind, and that neuroleptics are going to decrease their clenching and grinding, which is going to decrease their symptoms. Again, stated many times before, there is no on and off switch for bruxism. We know it's related to stress, no doubt about it. Half the population bruxes night and or day. Half the population, at least half the population, most of them are not aware they do it. And not everybody who bruxes has TMD disorder. They don't develop symptoms. You can brux a lot and not have any of these symptoms. So bruxism doesn't equate to TMD. Bruxism is one of the causes, integral causes of inflammation in the joint, which causes the symptoms. But we do not understand bruxism. There is a mechanism within the central nervous system under whatever level of anxiety that patient is experiencing that overstimulates the central nervous system and creates bruxism. Exactly where, and most likely in the brain stem, not on higher levels, but in the brain stem, these mechanisms are there. There's theories behind where they are and how they operate, but they're only theories. Actually, we do not know how bruxism operates, and that's what I tell patients. And I wouldn't suggest anyone out there tell people that you can get them to stop the brux, because I have never seen that happen. Once a patient is a bruxer, they will go up and down with their bruxing levels, and there are certain physical things they can do to help themselves with bruxing. Better diet, better sleep, less stimulation from personal anxiety. But if a person is going to brux, they're going to brux, and there's no on and off switch. So attempts to get patients to stop bruxing are not effective. In fact, there are several large medical centers, which will go unnamed, 2 of which I know personally, very familiar with, that have now brought in psychologists and psychiatrists to help treat TMD. I mean, the patient can just as well address their own anxiety. Certainly, it's not necessary to bring in a psychologist, but it's not necessary at all when you address the problem simply from decreasing the inflammation within the joint. So getting a lot of these other ancillary providers involved is pretty superfluous, actually, if you treat the cause. Amitriptyline, tricyclic antidepressants, again, kind of the same thing. I saw it commonly used. And then you can have the side effects of tricyclics, which when you take them long enough are quite severe. So again, you're not really treating the common denominator, the cause. You're just trying to suppress the patient's concern or their anxiety over it, or their basic anxiety, which hopefully decreases to some extent their bruxism. But once the joint is inflamed, whether or not they continue to brux or how often they brux, or it certainly can complicate it. But once the joint is damaged and it's inflamed, they're going to create some symptoms on that list. So again, that type of drug is long-term not effective, has significant side effects. And then just to remind everybody, as a physician, I've known since I was in medical school or even before, that when you prescribe a drug, I don't care what kind of drug it is, any drug for any reason, what you are prescribing that for is one of the side effects listed for that drug. A drug has many side effects. It's just a list of side effects, effects of that drug. You take that drug, you have some effects from that drug. Vernacularly, we call them side effects. And then the doctor picks out one of those side effects and says, we're giving you the drug for this, to get this effect. What he doesn't say, almost always, is that you will likely have some of these other effects, and they go along with the drug. Those are called side effects, but actually they're all side effects. And you give the drug for one effect, and you're married to the other effects that come along with it. That should be emphasized by all physicians, every physician, when they write that prescription. Now, the patient may accept it, may not accept it. They certainly need to know about it. So, neuroleptics and narcotics and tricyclic antidepressants, I'm not going to go through all of the significant, severe side effects that can come with each and every one of those. But when you give a drug, one or more of those drugs for TMD, you need to understand they're going to have some side effects that come along with it that are non-optimal significantly. But some of the side effects regarding, I've written down here, regarding tricyclic antidepressants, they are definitely not on my list of favorite drugs. I kind of looked this up just to verify this. Tricyclic antidepressants, amitriptyline being one of them, and I picked out amitriptyline because, at least here in Middle Tennessee, we have several doctors who will go unnamed. You go in to see them, and basically they will give you a prescription for amitriptyline. So here's the side effects for amitriptyline, tricyclic antidepressant: hair loss, nausea and vomiting, drowsiness, weakness, muscle weakness, nightmares, headaches. So you're trying to solve the patient's headache problem, and you give them a drug that can and does cause headaches, dry mouth, and constipation. So I think I made my point there. I don't see the advantage of trying to treat patients with drugs for TMD for TMD when you can simply decrease the inflammation, and you do it consistently, and all the symptoms go away and they don't come back if the patient uses the device. Orthodontics. It is common around here that I hear patients are complaining of one or more of the symptoms of TMD, and somehow they get into the office of an orthodontist, and they may or may not have crooked teeth. They may or may not have functional malocclusion, but they are told that orthodontics is going to fix their TMD symptoms. Well, let's go back a couple steps. Functional malocclusion is one of the primary causes of inflammation within the temporomandibular joint. That is true. Now, is functional malocclusion the only cause? No, there are two others. Trauma and bruxism create inflammation within the temporomandibular joint. So if the orthodontist is lucky by removing the functional malocclusion defined as significant difference between centric occlusion and centric relation, irrelevant of how the teeth are lined up aesthetically. We know that a functional malocclusion can and will damage the joint, creating inflammation. And so if he's lucky and the majority of that inflammation in the joint is caused by the functional malocclusion, which he just fixed, then he will help. It will help, but it won't help in all cases. And the misunderstanding of the other two causes by the orthodontist and the other symptoms that are involved frequently get the orthodontist put in a situation where he puts the patient through 2 years or more of orthodontic treatment, and then they continue to have temporomandibular joint pain and dysfunction and other symptoms, ringing, fullness, dizziness. He hasn't removed all the inflammation by just fixing the occlusion. I have seen that all the time, constantly. So it puts the orthodontist in a bad situation. He told the patient that it's going to fix and it's not going to fix because he really wasn't able to treat 100% of the inciting cause of inflammation within the temporomandibular joint. Surgery. Well, I have a lot of experience in trying to treat temporomandibular joint problems and disorder with surgery. I've done each and every kind of surgery multiple times. Both half of my 2,000 cases were open joint cases, opening the joint itself and doing various procedures within the joint, and closed joint procedures with an arthroscope. It's a lot of temporomandibular joint surgery. And that is the reason 11 years ago, I totally stopped doing any kind of surgery for the temporomandibular joint, because consistently, no matter what I did, including cases of total joint replacement, I have done my share of total joint replacement, and including those cases, the patient would be back in a period of time, anywhere between 2 months and 2 years or a little more, and they would be having symptoms again. And then, I did surgery, and what do you do now? More surgery? You do what you did again, you do it a second time. And I have to admit, I've done more than my share of that. That is why I quit doing surgery 11 years ago. Nowadays, you pretty much can't find an oral or maxillofacial surgeon who wants to do any kind of treatment, including non-surgical treatment, for the temporomandibular joint, because they all know nothing works. And that's not true. We've proven that. But that's just that because the oral surgeons have been burned so many times, and for the most part, they're very good people, they're very good surgeons, they have very high intentions. They go, I'm just not doing any more temporomandibular joint patients. I'm not doing any more temporomandibular joint surgery. There are a few out that still do, and those that do are pretty much limited to doing the highest end of total joint replacement when nothing else works, when you're at your wit's end, when the patient has tried everything else and they've been down the road around and around, they'll accept a total joint replacement, which is a very big operation with a lot of potential complications. How would I know? Because I've been faced with doing that procedure many, many times. It's a big operation. You have to really know what you're doing. There can be really some significant complications that can arise from doing that surgery inappropriately. So again, surgery is not the answer. We'd already talked about psychology and psychiatry for these patients. Yes, bruxism is definitely related to anxiety, no doubt about it. Is the psychologist or psychiatrist ever going to get the patient to stop bruxing? The answer is no. They're not going to do it. We don't understand the mechanism for clenching or grinding. So I believe, my opinion is that that kind of modality for treatment of TMD is a waste of time. Injection of drugs into the joint itself. Well known that injecting steroids into the joint can actually damage the surfaces of a healthy joint. Any other drugs can do so. Lysis and lavage, just going, entering the joint with a trocar and exiting the joint and irrigating the joint is common, usually performed as an office procedure nowadays. It can give temporary relief. It washes out the inflammatory fluids and can give some temporary relief. But with my own examples and examples I've seen in other oral maxillofacial surgery offices who do this kind of routinely, that patient would be back in their office within a short period of time with the symptoms, because they gave temporary relief and washed out some of the inflammatory fluids and exudates, but they're just created again within a short period of time. So really not effective over a long period of time. Stem cells is the latest kind of thought process. If you put in stem cells within the temporomandibular joint, it's not what you're doing. If you have TMD, you're putting stem cells into an area rampant with inflammation and inflammatory fluids and exudates and inflammatory cells, which by design are built to take any outside cells or tissue and do away with it. That's why inflammatory fluids cause tissue degeneration. So putting stem cells within the temporomandibular joint, although it is certainly not proven and no one claims it is not going to go anywhere. It's just not. And the last I want to talk about, and I don't want to belabor it, but Botox to paralyze muscles. The same applies that I talked about with other modalities. You can paralyze muscles of the face. And if that muscle is pulling on the bone, and by the way, again, to reiterate, the muscle doesn't hurt. Where the muscle pulls on the bone is where the pain is. That's where the nociceptors are. Muscle gets tight, pulls on the bone. It hurts where the periosteum, where the muscle attaches to the periosteum. So the muscle gets tight and you inject the muscle with Botox. It relaxes, it doesn't pull on the bone. For that particular muscle, it will not hurt. Brings to mind a patient every time I talk about this topic. I saw a woman many years ago, a young woman, who actually worked for a plastic surgeon and had tremendous TMD symptoms, jaw pain, neck pain, and more. But she had so much Botox that her entire face had a glow to it. It was shiny, and her facial muscles didn't work. She was only probably 30 years old, a very attractive girl, but because she worked for a plastic surgeon, she had access to this stuff. All her facial muscles were paralyzed. Fortunately, she still had mastication ability. Her jaw still went up and down, and she had significant temporomandibular joint pain and symptoms. That's why she was in my office. And she had the max Botox you could ever put in. I guess that kind of exemplifies what I'm trying to say. And then, of course, Botox will not address anything having to do with the middle symptoms of tinnitus, vertigo, and subjective hearing loss. You're only treating one symptom when the patient usually has 4 to 6 to 8 to 10 symptoms. But everybody is licensed to use a syringe now uses Botox. I have no problem with Botox for cosmetic reasons at all. But to use it and tell somebody you're going to treat their TMD disorders, you're actually doing them a disservice. And then other devices that unload the joint, and there are. I'm going to name them. And I'm not trying to be critical. I'm just trying to compare and contrast the effectiveness and what my experience is and how I came about this versus other oral devices that do disocclude the posterior teeth. And if you disocclude posterior teeth long enough, and you do it according to proper protocol that doesn't cause complications, the inflammation goes down, symptoms go away. So the other devices that I'm aware of, the Kois device, it's a mandibular device that goes in the mandible, has a little bead or a little thing on it. The problem with it, and it does disocclude the posterior teeth. The problem is you can't wear it long enough. It's really a diagnostic device. You prepare it as a diagnostic device. I have seen it used for temporomandibular joint disorders, but the problem is you can wear it at night, I guess, but you can't wear it during the day. You can't speak with it in your mouth, can't happen. And what we found with developing the protocol is you have to start out 24/7 to get the best effectiveness, 24/7 for usually 2 months. So Kois is a device that separates posterior teeth. The next one is the quick splint. I actually was first observed that several years ago. I thought it was pretty cool little device. The problem is it goes over the anterior 6 teeth. You put it in at home. You do a home procedure where you boil it and add your material and take your own little impression, and it separates the posterior teeth. But again, you can't wear it 24/7. You can't speak in it. You may be able to keep it in your mouth nighttime. It appears to me, I've had patients come in with it, and it appears to me it's hard to keep in even at night. But it does separate the posterior teeth, and being such, I think it does give some value. It gives some value to decreasing the inflammation within the temporomandibular joint. And the last one is the NTI, of which I think most of the dentists watching this episode will at least have heard of. That's the nociceptive trigeminal inhibition, NTI, nociceptive trigeminal inhibition device. It goes over the anterior teeth, has a little beak that sticks out. It does separate the posterior teeth. I'll let you read up on it. There's pros and cons about it, but it does separate the posterior teeth. But again, you can't talk with it. You cannot wear 24/7. And what we found most definitely is you have to start out strongly, consistently separating the posterior teeth 24/7 to get that inflammation started on down. Once you get the inflammation down to the point where the symptoms go away, then you can go to nighttime only. And even then, 15% of the patients find they need to wear it more during the day. What we find, 85% of the patients nighttime only is all they have to do. Once you get them comfortable and the symptoms diminished, and then 15% find they need to put in more during the day, which they usually tell me when I'm in traffic, when I'm on the computer, I figured out I need to put this in. So those 3 devices separate the posterior teeth, and they do give some benefit to decreasing the inflammation and decreasing the symptoms. The problem is you can't wear them long enough to be effective. So, and reducing bruxism, we talked about that extensively. So my point again is very simple. If you had a magic wand that just made this inflammation go away, that's all you'd have to do. And I don't have a magic wand. What I did figure out, what I did confront, what my patients told me was, if I put my finger in my front teeth, between my front teeth, it feels better. I made a device that separated the posterior teeth with a device that they could wear 24/7, that they could talk with. And they do talk, once they get their tongue off it, they have perfect speech once they get their tongue off of the device, which unloads the joint, which decreases the inflammation significantly, which then goes on to decrease the symptoms. Simple as that. And that's a comparison and contrast between a great number of treatment modalities that are out there being used constantly, in many of them to the detriment of the patient and at least not being effective. So for today, I have exceeded my time a little bit, and I want to thank you for watching. I want to thank you for your interest. Thank you for your participation. If you're a network provider, I really encourage you to help as many patients as you can, because that's why I'm in this. I'm in this to help as many patients as possible with this problem. We've solved the problem, and now we have a network of providers, growing network of providers throughout the United States who use it for their patients, who use it for the benefit of their practice. It's a wonderful thing. I look forward to speaking with you again. If you'd like to communicate with me, I am can be reached at Tony@tmjservices.net. Our network, our company executive, who is Director of Marketing and Education, Naomi, can be reached at Naomi@tmjservices.net. And for newcomers, you can always learn more about the Urbanek device and protocol and how you can become involved at www.tmjservices.net. So for today, thank you for your interest and participation. I look forward to speaking with you next time.